When a federal judge in Texas threw out the decades-old FDA approval of mifepristone, the order threatened the hundreds of thousands of abortion procedures that happen every year in the U.S. But the pill isn't just used to end pregnancies. It is also frequently prescribed to treat miscarriages. The Supreme Court temporarily halted the Texas judge's ruling, meaning that the drug should remain available while the case plays out. But if it is upheld, the ruling could drastically cut down on access to abortions across the country. It could also give every federal judge in the country the green light to toss out the FDA approval of other medications as well. Well, to break this down and discuss, I am here with Dr. Catherine White. She's a professor of OBGYN at Boston University, where she also serves as the Associate Director of the Complex Family Planning Fellowship, and Dr. Lou Ireland, a gynecologist at UMass Memorial Medical Center and the Director of Diversity, Equity, and Inclusion there. Welcome so much. Thank you so much for your time.
Thank you for letting us be here.
Thank you for having us.
So, Dr. White, I'll start with you. I'm going to ask you both this question, though. How serious is this conversation happening in the courts? And what I mean by that is, how serious is it to the way you practice medicine? And Dr. White, I'll start with you.
Crystal, it's scary on multiple levels. It's obviously scary on the very first level about what this could do to abortion access in the country. Medication abortion represents more than half of all abortions done in the United States. So this is really threatening a very common procedure that a lot of people have come to depend on. But as you said in the introduction, it also affects patients undergoing miscarriage care. 1 in 3 people having a pregnancy will have a pregnancy loss. So a lot of people also experiencing something as devastating as a miscarriage can be affected by this ruling. And also, as you said, it's any medication that possibly now could come off the market. HIV treatment, gender affirming therapy, vaccines. If this suit is allowed to actually go through all the way to the Supreme Court, it feels like the entire foundation of how we practice is in jeopardy.
Dr. Ireland, I imagine this is also an equity issue as well, compounded upon all the other things that Dr. White mentioned.
Absolutely. As a physician, the way I provide patient care is really guided on my medical training, the medical evidence, lots of research that tells me how effective and how safe medications are. And we have 20 years of experience on the safety and efficacy of mifepristone. And it really has become a cornerstone in the way that we provide first trimester abortion and miscarriage management. Not only does it set a dangerous precedent, we all know politics don't have any place in the FDA approval process. And this sets a dangerous precedent for political action against other controversial FDA-approved medications, whether that's misoprostol, which is also the partner medication used with mifepristone, gender-affirming hormone therapy, medication-assisted therapy for opioid use disorder. We can already see over the last year how a person's ability to access evidence-based abortion care is largely dependent on the zip code in which they live. In certain states, like the state in which I practice of Massachusetts, we are able to provide the full spectrum of abortion care. And that's very different than our colleagues in Texas, our colleagues in Oklahoma, Florida, et cetera. This is a profound equity issue because patients who have the means will always be able to travel to another state. The folks that are not able to travel to receive the care that they deserve and that they need are always going to be our patients from more marginalized community. And those are our patients who are Black, brown, who are transgender, part of the LGBTQ community. And it really sets up a system that is based on inequity.
Dr. White, talk to me about how mifepristone is prescribed, because I think a lot of folks assume it is similar to the morning after pill, where women, get it prescribed and then that's it. It's a sort of a flippant type of process.
Sure. So mifepristone, as Dr. Ireland said, is the first drug that's used in a medication abortion process. It can usually given in a doctor's office, though these restrictions were lifted during the pandemic, and now patients can very often have the medication mailed to them. It's usually given after a visit, either in person or by telemedicine, with a provider who asks them a lot of questions about how pregnant they are, what their medical history is, making sure that this medication is the right one for them. Then the medication, along with misoprostol, is sent for patients to use with really clear instructions at home.
And it's in terms of it being used to treat miscarriages, I mean, the alternative is surgery or someone, possibly having a life-threatening infection, if I understand it.
Yeah, we are all about patients having as much choice as possible in healthcare. And this is what all family planning providers and all healthcare providers feel. And so there are patients who prefer to wait out a miscarriage and let it happen naturally, or patients who really want the efficiency of surgery. But for patients who don't like either of those options, medication is perfect. It starts the miscarriage process so they can get on with this pregnancy, they can heal and grieve, and then possibly get pregnant again. And we know that when options are taken away from people, it makes them more hesitant to seek medical care at all. It can lengthen the time that it takes for them to get into a provider, causing way unnecessary complications.
Dr. Ireland, I mean, I imagine, as we were just talking about equity, already the healthcare system, the women's healthcare system specifically in those institutions can be intimidating, especially for people of color, maybe folks who are low income, maybe folks who don't have open conversations about what women's healthcare looks like. So having this drug taken out of the toolbox, how big a challenge can that be in doctors' offices?
I mean, it can be quite a challenge. Like Dr. White said, so much of what we do in healthcare relies on supporting a patient's autonomy. Only a patient knows what it's like to be in her shoes and what process is going to be the least traumatic or the most healing for her in choosing to end a pregnancy, whether that's for abortion or miscarriage. When we think about communities that have historically been harmed by the medical system, and that's largely our patients of color, our patients with limited English proficiency, so much of that harm has been based on the medical system taking away somebody's ability to choose what is right for them, or a lack of honoring a patient's autonomy. Removing this very safe option for early pregnancy termination or miscarriage management falls exactly in line with that. It is removing an option and the ability for a patient to choose how to end their pregnancy on their own terms.
Dr. White, we know that the birth outcomes for women in the United States are much worse than people imagine that they are. So having this debate, having this drug possibly being taken again out of that toolbox, out of the realm of use there, for how will that affect health outcomes for birthing people in the U.S.?
Pregnancy can be a really wonderful time. Starting a family, growing your family. But pregnancy is really dangerous. We don't tend to counsel pregnant patients on how dangerous pregnancy can be. Ignorance is bliss, and for people who really want a baby, that is the most driving force for them. But we all know that the complications in pregnancy, including death, are magnitudes higher than terminating a pregnancy. It's not a reason to terminate a pregnancy, but if you find yourself in the position of not being able to stay pregnant, an abortion is the safest thing you can do for your health. And we know that whenever we restrict abortion access, there will be people who can't access it at all, who will then go on to have babies, to have newborns that they were not intending to have, which is going to absolutely increase bad pregnancy outcomes. And in a country where the maternal morbidity and mortality rates are rising every year, it's unconscionable to think about people having to stay pregnant who would have had an option otherwise.
Dr. Ireland, what are you hearing from birthing people or pregnant people in your practice?
I mean, I think the thing that we are hearing most from both our patients and our colleagues is massive confusion. It's really hard to keep up with every new ruling, every new headline about what the state of mifepristone is. Is it accessible? Are we allowed to prescribe it? Are our patients allowed to take it? And I think it's really important to highlight that that is the exact intent of these court cases. This is the exact intent of these rulings. It's to create a situation in which folks are confused, where physicians are afraid to provide care, evidence-based and safe care, because they're not sure what the legal implications are, and it causes confusion to patients and creates hesitancy in them speaking to their doctors honestly about the care that they want and the care that they need.
Dr. White, you serve as the Associate Director of the Complex Family Planning Fellowship there. What are you counseling, I guess, doctors, junior doctors under you that you're helping guide through that program when, you know, they are just learning best practices in this space and in counseling patients through this?
Like Dr. Ireland, I feel really lucky to be in Massachusetts right now, whose legislature and governor have fully affirmed their support for people's reproductive health access. And so when we have medical students and residents and fellows come through our hospital, we get to train them on all aspects of comprehensive evidence-based care. But then they have to eventually look for a job or a residency training program somewhere else. And we're telling them that the nirvana that is Massachusetts right now is not what the rest of the country is looking like. Every day there are more abortion restrictions in other states. And so for people who have a specialized skill set to be able to take care of really complicated pregnancies and be able to perform abortions for people who need them, it's really making them decide, where do I want to go further my training? Where do I want to move my family to? Because this is how I was trained to take care of patients. Why would I want to go to a place where I can't use those skills?
Absolutely. It's a great point. Dr. Ireland, I'm going to ask you both this question. What are you telling patients or folks who might be watching this segment right now who are concerned about what this looks like, what their healthcare looks like in the wake of this complex issue moving through the courts? What are you counseling patients, and what would you tell folks who are watching this? And Dr. Ireland, I'll start with you.
Yeah, you know, it's an interesting predicament to find yourself talking to patients and reinforcing the need that the kind of care that they seek and the kind of care that they need is going to be dependent on the laws of the state in which they are. Never before have I ever had to do that for patients. So that is a very new and unpleasant reality of providing health care. You know, in addition to providing abortion care, I also provide obstetric care, and I have prenatal patients who ask me about travel. And whereas our travel conversations were used to be focused on staying safe, not catching COVID, not getting a blood clot, now they're focused on, where are you traveling? If you run into a pregnancy complication, are you going to be in a state where you can get the care that you need? And that is a very somber conversation to have with a patient. You know, to Dr. White's point about figuring out where you're going to practice medicine, you know, one of the hats I wear is making sure that we are providing as equitable care as possible. We know very well that there is a lack of obstetric care providers in rural areas, that there are some parts of the country where folks have a hard time getting to a nearby hospital for any pregnancy care whatsoever. And we know, we are already seeing in the way that medical students are applying to OBGYN residencies and the way that residents are applying to jobs, that they are starting to avoid these states. States that are hostile to abortion and reproductive rights are going to see an exacerbation of lack of medical providers, lack of obstetric providers, and I really worry about the worsening pregnancy outcomes for folks in those states.
Dr. White, in the last 20 seconds or so, any final words here?
These headlines are scary, and I have to reassure patients that all this confusion is not about safety, and it is not about health. It is about control. The healthcare that they're getting right now is as safe as it's ever been. But we also know that even though we've been lucky enough to be in a state that currently supports this access, we are one presidential election away from potentially losing it across the country. And so for patients who like to think that politics don't affect them, it actually does. It affects the care that they're going to be able to be given, the care that their daughters or their children may receive. And so even though things look good right now and are as safe as ever, the future is really uncertain, and that's scary for all of us.
Dr. Corinne White, Dr. Lou Ireland, thank you so much for your time.
Thank you.
Thank you for having us.